Hello, and welcome to From the EBPL Archives, Encore presentations from the East Brunswick Public Library. I am your host, Melissa Hosick. This event was presented as part of our Just for the Health of It initiative. Just for the Health of It is a proprietary health literacy program developed by the East Brunswick Public Library to promote health literacy in Middlesex County. To learn more, visit justforthehealthofit.org. Now, enjoy the program.
Okay. Welcome and thank you for joining us this afternoon for today's Lunch and Learn with the Doctors. My name is Kathy Chern and I am a consumer health librarian at East Brunswick Public Library. This program is brought to you by Regional Cancer Care Associates Central Jersey Division, Princeton Radiation Oncology, and the library's Just for the Health of It initiative to promote community health and wellness. Our speakers today are Dr. Michael Nissenblatt, medical oncologist, Regional Cancer Care Associates Central Jersey, and Dr. Edward M. Soffen, radiation oncologist at Princeton Radiation Oncology. Please be aware that this talk is being recorded, and please keep your microphones muted and your webcams off. The recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. The doctors will answer questions at the end of the talk. The doctors presenting will not be able to offer personal medical advice to attendees during this program. And without further ado, I will turn things over to Dr. Nissenblatt and Dr. Soffen.
Well, thank you very much for having us. We're absolutely delighted to participate and to educate, as well as to learn from you. Dr. Soffen and I have been working together for years. We've worked hard on today's presentation, and we hope that you gain from our efforts. The first slide shows what I would consider to be a visual paradox. You see a cloud on top, a huge boulder in the middle, seemingly elevated. And so it's entitled Artists Create Puzzles and Scientists Solve Them, and that's what we're going to try to do. This, of course, was done by Renee Magritte many years ago. The name of the talk is called Gynecologic Cancers, Options and Opportunities. And these are the good-looking men who are presenting today. We have worked together for many, many years. Gynecologic oncology is one of the fields that we consider to be quite experienced with. Female lifetime risk of cancer are listed here. These are the major malignancies. As you can see, breast cancer will occur in 1 out of 8 women throughout their lifetime. And if even one first-degree relative, meaning a daughter or a mother, have had breast cancer, then that risk nearly doubles. Lung cancer, though less common, is still rather common, even among non-smokers. Women who are non-smokers have a significant risk of developing lung cancer, more than we used to think. The lifetime risk is 6%. Colon cancer, about 5%. Endometrial cancer is about half of that. And the arrow is pointing to the endometrium. The lifetime risk is 2.5%. And the arrow here is pointing to the ovary. The lifetime risk is 1.4%, but very much like breast cancer, if there is one first-degree relative, the risk nearly triples. Ovarian cancer will affect about 20,000 women per year, but the great impact is on the death rate. Nearly 14,000 women die in this country from ovarian cancer each year. The other malignancies, uterine cancer, that's endometrial, 65,000, and cervical cancer, 13,000, are listed just above that. This slide shows that over the last 20 years, the overall rate of ovarian cancer has been slowly dropping. It used to be 15 new diagnoses per 100,000, and it is now running around 11 per 100,000. It is still a substantial number. And because not everyone can be cured, it has a major impact on quality of life and on life. The average age of developing ovarian cancer is 63, but you can see that there are some who are very young, even 20 to 35, and some who are markedly older. Interestingly, those who are particularly young may have a genetic reason for that, genes that you will hear about and may already know about. And those who are particularly old may also have a gene. On the left, the young ages, we usually think about BRCA1. In the middle, we can think about BRCA2, and at the extreme older ages, we can also see BRCA2 quite remarkably. This slide shows the cure rate. In the purple on the top, early stage ovarian cancer is associated with a very high cure rate. Middle stages, where it's, and I'll show you what that means in a moment, still have a very good cure rate of 2 out of 3. The more advanced stages, 3 and 4, are the ones that we are concerned about. Overall, the survival is about 50% at 5 years. So where does ovarian cancer start? It seems to be obvious, doesn't it, that it would begin in the ovary, as seen on this slide? But it can also begin in the fallopian tube, which connects the uterus to the ovary and carries an egg into the uterus for implantation and fertilization. But there's a third spot, and that is the peritoneum. The peritoneum is a shining, glistening membrane that covers all of the organs inside the belly and also covers the inside cavity of our belly, underneath our skin and underneath the fat pads. It's a shining, glistening membrane. Cancers that look like ovarian cancer can begin in all 3 of those areas, the ovary, the fallopian tube, and the peritoneum. And they can appear differently under the microscope, sometimes being very liquidy or serous, or viscous or endometrioid, and mucinous. There's another rare variant called clear cell. We will not be talking about non-epithelial ovarian cancers, such as sarcomas, such as germ cell tumors, which, by the way, means that very rarely a woman can develop the equivalent of testicular cancer, even though it's coming from the ovary. We're going to be talking about the most common forms. Here on the left is an arrow in the orange, pointing to where the fallopian tube or ovary cancer begins. In the middle are what they look like under the microscope. And on the right is a picture showing very rapidly growing ovarian cancer, therefore called high grade. The pictures on the bottom on the left show a very, very large cystic mass in the belly seen at the time of surgery. That is how ovarian cancer may look. And on the right, the green arrows are pointing towards large masses growing on the surface of the organs, the surface of the bowel. And that is why sometimes ovarian cancer may cause blockages. So what causes ovarian cancer? We usually see it in older age. Frequent ovulation suggests that injuries that don't heal properly, in other words, when the egg is ovulating, it produces a bleeding site, the Mittelschmerz, on the surface of the ovary that can leave a scar. But those scars can rarely become ovarian cancer. Oral contraceptives reduce the risk. These are things that we all know about. But the things that are most important are family history and the possibility of a hereditary mutation that can cause ovarian cancer. The most common genes that cause ovarian cancer are when there is a defect in BRCA1 or 2, but there are others listed in the purple column on the right. In my own experience, I have seen people with BRCA1, BRCA2, ovarian cancers from PALB2, from NBN1, from RAD51C and D, from MRE and BRAD1, and several people with ATM. Although they're uncommon, all of those genes on the right may be related to the development of ovarian cancer, or as I showed before, fallopian tube cancer or peritoneal cancer. These are important for multiple reasons that you will shortly learn about. What are the signs and symptoms of ovarian cancer? Well, many times there are no signs, no pain, no swelling, no change in bowel function, no nausea, no complaint whatsoever. And so that is why we do recommend that women continue to have regular pelvic examinations, since the lifetime risk is modest. But these are the symptoms, if they are present, which do occur: abdominal pain, bloating, shortness of breath because of fluid developing on the surface of the right lung, or shortness of breath because of fluid in the belly, swelling the belly and pushing the diaphragms north, making it difficult to breathe. There can be changes in taste, smell, or muscular pain. Years ago, I remember walking down the corridor of my hospital with one of my nurse practitioners, and a woman screamed about 60 feet away from where we were. And she complained of pain, very unpleasant pain in her nose. As it turned out, she was detecting the perfume that my nurse practitioner was wearing. And she had a heightened sensitivity to that odor, and it made her very uncomfortable. My nurse no longer wears that perfume. Occasionally, the ovarian mass can result in torsion and severe pelvic pain. This slide shows images of it. It can be asymptomatic, no complaint at all. Abdominal bloating or change in bowel movements, satiety, a pelvic mass. Here is a picture of fluid in the belly, the top arrow. There can be a belly button nodule called a Sister Mary Joseph node and fluid in the pelvis. Or here, there can be fluid in the right lung causing shortness of breath. There are a number of blood studies that we use in evaluating women with ovarian cancer, but I choose those words carefully. We do not get these bloods indiscriminately. These bloods are not usable and are not useful to make a diagnosis of ovarian cancer. These bloods are useful to help us follow a woman who already has a diagnosis of ovarian cancer. So going to your gynecologist or oncologist and asking for the test is not helpful. The diagnosis needs to be made first. CA-125 is one of the most important proteins. It has a normal function. It makes a protein called MUC16, which actually is a lubricant. It is the substance that makes our intestines shine when a surgeon operates on us. It prevents our organs from causing friction when they rub up against us, when they rub up against each other, and when they squeeze in order to have a bowel movement. And the reason it is not valuable in diagnosis is because there are other things that can elevate it. For example, a person with an inflamed bowel from peritonitis, even a pneumonia that inflames the surface of the lung raises CA-125. Any operation on the belly will raise it. Even placing a needle through the belly to drain some fluid or to look for an infection will raise the CA-125 level. Only levels that are exceptionally elevated, meaning 10,000 or more, can be helpful for making a diagnosis of it. A normal level is less than 35. Less known is another protein called HE4. Like CA-125, it also has normal function. It helps in men in the maturation of sperm to activate them. It helps in inflammation. It has a role in controlling infections. Like CA-125, it is not useful in making a diagnosis of ovarian cancer. Both of these proteins are useful only in monitoring a woman's response to treatment of ovarian cancer. How is ovarian cancer staged? Well, on the left, if the ovarian cancer involves one or two ovaries, that's stage 1. If it involves the pelvic organ, as well as the ovaries, that's called stage 2. A pelvic organ means the uterus or the cervix. Stage 3 is annotated if there are lymph nodes involved. And stage 4 means that there's disease outside of the pelvis involving the liver or involving the lung or other places. I would like to tell you that ovarian cancer rarely involves the inside of organs. If it involves an organ, it usually involves the surface of organs. It is a surface spreader. If it involves the liver, it's not the inside, it's usually the surface. If it involves the lung, it's normally not the inside, it is the surface and causes fluid. Even if it involves the brain, it is not the inside, but it involves the surface. Who needs chemotherapy? Well, this is on the right, on the top. That purple line looks at the overall survival of women who are treated only with surgery. And you can see that over a decade, the long-term outcome are unfavorable for advanced stages of disease. I showed you that on an earlier slide. So after surgery, we give chemotherapy either in the bloodstream, which is IV, or in the belly, which means IP. But we do it for stages 3 and 4 disease rather routinely. And oftentimes we will add a drug called bevacizumab to make the effective chemotherapy more successful. There are women, however, who cannot get surgery first because either they are too ill or too symptomatic, or the amount of cancer which is there is too profound for the surgeon to approach. And therefore, we like to give treatment with chemotherapy before surgery is performed. Does that affect the outcome? It sure does. It makes people capable of having the surgery. I've seen many women who are sick from nausea and vomiting and weight loss, malnourished, who would never heal up after surgery if the surgeon took them to surgery because they're too weak. So if we give them gentle chemotherapy, when I say gentle, it means giving them a low dose of treatment every week, or if they're a little stronger, a moderate dose of chemotherapy every 3 weeks, we're able to reduce the size of their disease after 3 courses of treatment and then take them to surgery. And here you can see that the outcome is the same, but we were able to get them into surgery. If we didn't do the surgery, we would not have had a chance of helping them at all. But you can see it's not good enough. The outcomes are not better than if they had surgery at the outset. But can we do a little better? Sure. Because now what we're doing is that after induction chemotherapy for 3 months, when we take them to surgery, we do something which is called HIPEC, which means high intensity and hyperthermic, meaning with heat, and chemotherapy in the abdomen. This picture shows a number of lines entering the abdomen. And when the surgery in reducing the masses are performed by the gynecologic surgeon, the surgeon closes the abdominal cavity and leaves ports that circulate heated chemotherapy into the belly. And there was a gentleman by the name of Getzenberg at Johns Hopkins who found that heated chemotherapy is particularly effective in a number of diseases, most particularly in ovarian cancer and in testicular cancer. Strangely enough, Lance Armstrong was thought to have been successful because he consumed, remarkably, between 12 and 15,000 calories of food every day when he was doing his the Tour de France and other tours. We now know that he was successful for other reasons, not just because he was cured of testicular cancer. However, in ovarian cancer hates heat, and therefore heated chemotherapy takes advantage of the success of chemotherapy and the added benefit of the heat. It's usually heated at 120 to 135 degrees. People need to have adequate kidney and liver function, and that was described by Dr. Getzenberg. And here's the outcome. In the black line on the left is the outcome of women who had neoadjuvant chemotherapy first, followed by surgery, but no heated chemotherapy. And in the brownish line with the orange arrows, that's the effect, the added benefit of heated chemotherapy. And on the right is the survivals. And survivals are improved by between 10 and 15% by giving the heated chemotherapy, which we are now doing because the high intensity heated intraperitoneal chemotherapy provides an advantage to both survival and freedom from disease. So that is the reason that the 89% on the top for early stage disease and the 66% in the middle for middle stage disease is good, but the lower survivals are not good enough, but we are moving in that direction. We're moving in that direction because of better surgery, better chemotherapy, and heated intraperitoneal chemotherapy, but for a number of other reasons that we're going to get to. The reason survivals are not 100% are because relapse is common after the initial treatment. Even after 1 year, a third of women have a relapse. After 2 years or 3 years, 2/3 or more may have a relapse. But interestingly, the longer period of time that a woman goes without relapse, the more successful the repeated chemotherapy or the repeated treatments are. Here are in the green bars are the response rates to the second line of chemotherapy based upon whether or not they had only a short response, meaning 3 months before they reoccurred, in which case on the right you can see only a 10% response, or if they went 18 months before there was a relapse, at which time there was a very high response. And therefore, the longer length of time that a woman remains free of relapse, the greater likelihood it is that she will respond to the next line of therapy. I have a lady right now who was diagnosed in 2002 with a massive ovarian cancer so that she could not eat or drink. She had lost an enormous amount of weight at age 38. They could not even operate on her. Her CA-125 level was 4,500. I gave her nourishment in her bloodstream, chemotherapy for 3 months. We then operated. We continued the chemotherapy, and she was disease-free until 2007, at which time there was a relapse in December with a CA-125 of only 57. We gave her additional chemotherapy in very low dose, and she responded, achieved a complete remission, and after 6 months, she has remained free of disease for the next 13 years. And I see her every 3 or 4 months now, and she remains perfectly well. Who needs genetic testing? Well, as you'll shortly learn, everyone needs genetic testing. In a very large study from the University of Washington, 1 out of 5 women with ovarian cancer have a genetic reason for developing ovarian cancer, either the common ones, that the BRCA1 and 2 that you've heard about, or the ones on the right that I've mentioned. But it does a few things. It informs us about the risk of the developing ovarian cancer or other cancer, and it also informs us about the selection of treatment. Here, and I just selected one slide for BRCA1, we know that BRCA1 is associated with a very high incidence of breast cancer and a very high incidence of ovarian cancer. The incidence for BRCA1 is 15 to 45%, and 2/3 of those are before the age of 45. For BRCA2, the lifetime incidence is between 11 and 17%, and interestingly enough, 2/3 of those are after the age of 45, and they can even be into their 80s for BRCA2. But other cancers may occur as well, as are listed on the bottom. Having a genetic mechanism also informs us about the selection of treatment. Here is a strand of DNA. And as you can see in this circular tube, the top strand is broken, and I listed that as a single strand break. If that is not repaired, it becomes a double strand break. Now, women with all of us have a gene called BRCA1 and BRCA2. Dr. Soffen has BRCA1 and BRCA2. Dr. Nissenblatt has BRCA1 and BRCA2, and most of you who are listening have BRCA1 and BRCA2 that is normal. But BRCA1 and BRCA2 are responsible for repairing the double strand of DNA. So in a normal cell, the BRCA1 and BRCA2 repair it, and the cell survives. But if BRCA1 and BRCA2 are damaged, then the broken strand does not survive. It cannot be repaired, and the cell dies. So if we could find a way to increase double-strand breaks, we would increase the cell death of the cancers that have the double-strand break. And we now know that the protein called PARP is responsible for fixing single strands. So if we impaired PARP and PARP was not available, the single strand would develop into double strand breaks and there would be greater cell death. And we now have a number of drugs that can do that. Here is, you can see the repair genes are the repair men, were labeled as BRCA1, and they're repairing double strands. Here is the PARP, which is like a parachute that saves us if there's a single strand, and it'll prevent the single strand from becoming a double strand break. And there is the parachute, the guy with the parachute. But every once in a while, if we were to give PARP, for example, a PARP inhibitor, you're free sailing without a parachute, and you'll, instead of having a single strand, you'll have double strand breaks. And as a result, the cancers will die. So if we could get increasing single strand breaks, we could get greater survival. Here is the outcome of women who have had chemotherapy and then get placebo on the bottom in the green. After 3 years, only 27% of women are free of recurrence. But if we give them a PARP inhibitor, and there is the name there, it doubles freedom from reoccurrence, a major, major benefit seen in this study. More recently, a study combined both olaparib and a vascular agent called bevacizumab, and now we have improved the outcomes even more. We've doubled the outcomes at 1 year and at 2 with no progression of disease. And so now for ovarian cancer, after initial chemotherapy, we give maintenance therapy listed here in order to prolong the freedom from relapse, and often we do believe increase overall survivals. So the evolution of treatments in ovarian cancer are listed here. In the 1960s and 70s, we had primitive therapy. It got better in the 70s when we had platinums, and when we developed vascular endothelial growth factor inhibitors. But we've made some major, major advances with the use of the drugs that are listed here as I've described. Dr. Soffen will now be speaking.
Well, first of all, thank you again for inviting us. I hope everyone can hear me. And I want to thank you all for joining, because without you listening, it just increases the meaningfulness of our preparation. It's very hard to follow Dr. Nissenblatt. He's an amazing educator, both to the public and to patients and to physicians. Honestly, I learned a lot during that half-hour talk. Before I went to medical school, I auditioned on Broadway and was, unfortunately unsuccessful in creating a career in entertainment. But it's hard for me to get in front of an audience, as I'm doing now, without doing some type of shtick. So since I'm not prepared to sing a song, I thought maybe I would do a vocal impersonation. So if you'll bear with me, hopefully you'll recognize this voice if you're over 50.
You say, this is Jimmy Stewart here. Yeah, 30, 40 years ago, you didn't even talk about cancer of the female areas. You were embarrassed. You didn't talk to your neighbors about it. They were afraid that they could catch it. But now, look at you. You've got these new chemotherapy and immunotherapies and the PARP inhibitors. You've got some new radiation techniques, and so it's not a time to be scared. It's a time to feel like we're fighting this. We've got a chance, and I want to thank you for feeling the optimism. Yeah.
Okay, I'm assuming that you're all applauding, and now I can go on with my talk. So I'm going to talk about two types of gynecologic cancers that have a radiation component. You know, I don't know if you saw on that slide from ovarian cancer, years ago, before we had platinum, we did treat ovarian cancer with radiation. We treated, it was called whole abdominal radiation. The letters were WAR, war, because that's what it felt like when we treated women. Treating the entire abdomen with radiation was fraught with lots of side effects, tremendous toxicity, and now fortunately with some of the more advanced and very active chemotherapy agents, ovarian cancer is typically not something that we use radiation for. But we do use radiation for cervical cancer and endometrial cancer. So I'm going to start talking about cervical cancer. But first, conceptually, Dr. Nissenblatt is a medical oncologist, and he deals with cancer from a systemic standpoint. I'm a radiation oncologist, and I look at cancer from a local or a regional perspective. Now, oftentimes we look at cancer as both a local disease and a systemic disease, and so we have to integrate chemotherapy with radiation to effectively treat the patient. But sometimes we can use just chemo or just radiation, depending on what type of cancer it is and where and how it may spread. So cervical cancer in the early stages is one where we don't really need chemotherapy. It's a radiation type of cancer. Now, let me have the next slide. It is the third most common gynecologic cancer. I used to see this much more often than I do now. When I first started as an attending, there was a period of time of about 6 months where I only treated gynecological cancer, endometrium and cervical cancer. That's what I did all day, every day. And now we're seeing the incidence worldwide drop dramatically, mainly because of pap smears for early detection and because of the Gardasil, the HPV vaccination. So HPV, which stands for human papillomavirus, is associated in almost every cervical cancer. 99.7% of the time, the pathologist can find remnants of the DNA of the human papillomavirus. It's associated with both types of cervical cancer. There's squamous cell and there's adenocarcinoma. So both of them are associated with chronic infections with the HPV. Now, HPV, human papillomavirus, comes in many different subtypes, just like the coronavirus, just like other viruses, the rhinovirus, the common cold. There are probably greater than 100 HPV serotypes, but only about 10 of them have malignant potential, are carcinogenic. And the Gardasil, which is the vaccination now, I don't know how many years it's been around, I think maybe 10 or 15, maybe 20 years, significantly protects against all of the serotypes of HPV. This Gardasil is recommended in adolescent or pre-adolescent girls and boys, typically around age 11 or 12, hopefully before they become sexually active. And for a number of years, it was recommended when it first came out to immunize kids and young adults up to age 26. It was felt that by age 26, you were almost certainly exposed to HPV, and your body had either eliminated it completely, as it does almost all the time, or it had already set up some type of chronic infection. Now the FDA has increased the age at which it's recommended up to 45. I know that there was a question about if you're 50 years old and a virgin, is there a reason to get the Gardasil? And the answer is yes. Typically, the latency of HPV infection may be 15, 20, or 25 years, but there's no reason if you've never been exposed to sexual contact, it's probably not too late to get the Gardasil immunization. Now, risk factors for cervical cancer, as I mentioned, they're HPV related, associated with early onset of sexual activity and multiple partners. The greater number of partners and the earlier you start, the more likely one would be exposed to HPV. Lower socioeconomic status and cigarette smoking. You know, when you inhale cigarette smoke, the carcinogens don't just affect the aerodigestive area in the lung. The carcinogens are absorbed in the blood, they go throughout the body, and they can put other organs at risk for malignancy. Oral contraceptive use has been associated with a slightly higher risk of cervical cancer. The thought being that the monthly menstrual flow, which is inhibited by oral contraceptive, that the flow may help to exfoliate some of the infected cervical cells. They get washed out of the body more likely, and it's less likely for those cells to develop a chronic infection of HPV. And we have found that women have a lower risk if their partners are circumcised. And the feeling is that the foreskin may it may be more likely to harbor a chronic HPV infection, which can then be spread to the woman. Next slide. There are basically two treatment options for early cervical cancer. One is surgery and one is radiation. The cure rate is the same. Now, some women may want to preserve fertility. So if a young woman has early stage cervical cancer, she may not need a hysterectomy. If it's very early, like a stage 1A1, that means less than 3 millimeters of invasion. The surgeon, the gynecologic oncologist, may be able to do a cone biopsy or a trachelectomy. That means just a segment of cone is removed from the cervix, or a cylinder is removed. And that way the woman can preserve her uterus, can preserve her ovaries, and may be able to bear a child with the help of a cerclage, a suture in the cervix, because the cervix may be weakened by the cone. Some women, if it's a more deeply invasive tumor, will have a radical hysterectomy with a lymph node dissection. Now, if we find at the time of surgery in these early stages from stage 1 to 2A, if we find risk factors for a local or regional recurrence, we may want to give adjuvant chemotherapy and radiation. So if a woman has surgery and we find that the tumor was greater than 4 centimeters, if there was invasion of the cancer cells into the lymphatic channels, if it invaded deeply into the substance of the cervix, we call that deep stromal invasion, or if there was spread to the lymph nodes, that woman would be a candidate to receive adjuvant chemotherapy and radiation. We like to choose just one option, either surgery or radiation, but sometimes we choose surgery and we find out postoperatively from the pathology report that the woman probably would benefit from some adjuvant therapy. Next slide. Older women may choose, postmenopausal women may choose to have radiation for their early stage cervix cancer if they have other underlying comorbid issues, if they don't want surgery. And again, for early stage disease, the cure rate with surgery or radiation is virtually identical. Younger women may want to avoid some of the long-term effects that they might see from radiating their pelvic viscera, their bowels, their bladder, and their rectum by avoiding radiation. So it really depends on the age group and their overall general health. Next slide. When the cancer has grown beyond the cervix or the upper vagina, that would be a 2A, is where this cancer has grown into the upper vagina, then we know that surgery isn't going to cure the patient. We know that the patient would need adjuvant radiation. So then we will typically avoid surgery and treat with radiation alone. Treatment with radiation can be given with chemotherapy or without chemotherapy, depending on the overall health of the patient and how invasive the cancer is. And the radiation can be given in 2 ways. One is external beam radiation. We call that teletherapy. If you think of a telescope as being something that allows us to look at a far distance, the teletherapy means that the radiation source is at a distance from the patient. That's external beam. The other type of radiation is called brachytherapy. Brachy meaning short, because the radiation source is very close to or inside the patient. Gynecologic cancers offers us an opportunity to use brachytherapy because there's a cavity the vagina or the uterus and cervix. That's a cavity where we can get radiation in, and offers us an opportunity to get very high doses of radiation because we're not going through the external body. And that's why radiation is so successful in gynecologic cancers, because of the anatomy, because of the way the vagina and the cervix is, we can get radioactive material in, and we take advantage of something that we call the inverse square law. I'm going to go into that in just a few minutes, but basically, when you move a certain distance away from a radiation source, the dose of radiation drops off very dramatically to the inverse square of the difference. Think of it as 1 over x squared. If you move from 1 millimeter to 2 millimeters, that's doubling the distance, the dose is 1/4. If you go from 1 millimeters to 3 millimeters, that's 3 times the distance, the dose is 1/9. And then 1/16. So we get a very high dose of radiation and then very rapid fall off. And that allows us to treat very aggressively. I could eliminate every cancer if I could give as much radiation as I wanted, but the normal tissues get in the way. We have to respect the tolerance of normal tissues to the amount of radiation. Again, because it's gynecologic, because there's a cavity, we can get radiation inside the patient. And also, HPV positive squamous cell happens to be very sensitive to radiation. Next slide. These are types of brachytherapy apparati for cervical cancer. I don't have a pointer, but you can see like the thin tubes. The tube goes into the uterus. Those egg-shaped things are called ovoids. They go and nuzzle up right against the cervix. And then through those tubes, we can send a very active radioactive source that will dwell in certain positions along the tube, giving off radiation internally with very rapid fall off. The bottom one you see is a tandem. We call the long tube a tandem, and then there's a vaginal cylinder, there's ovoids, and the bottom one is a cervical ring. So the source will go in and sweep around the cervix in a ring-like fashion, again, delivering very high doses to the cervix and to the endometrium. Next slide. This is a dose distribution that we can see. Remember, I said that the dose falls off very rapidly. If you think of the dose in red as a very high dose, you see the green line and then the blue line. That represents 50% and then 25% of the dose. So there's very rapid fall off of the dose around these applicators. Next slide. Sometimes the cervical cancer grows through the os. The os is the center of the cervix. It's the area through which we can put the tandem in. Sometimes it's scarred down and we can't get the tandem in. So we will do interstitial brachytherapy. That's where we stick needles into the tissues. There's a vaginal cylinder, there's a template, and those needles go into the tissues. And again, we can send the radioactive source into those needles to give very high doses internally. Next slide. This is a dose distribution of that Said template, the interstitial brachytherapy. You can see the red line is the high dose, and then the green line, 50%, the yellow line, 10%, and 5% is the green line. So there's very rapid fall off of dose. And again, that's what allows us to have such a high cure rate for cervical cancer. Next slide. Dr. Nissenblatt mentioned endometrial cancer, 2.5% lifetime risk. You see the endometrial lining where the slide is pointing. That's where the cancer starts. But the endometrial cancer can grow into the myometrium. That's the muscle of the uterus. It can grow up the fallopian tubes onto the ovaries and splatter or give satellite areas in the pelvis, or it can grow down into the cervix and the upper vagina. Next slide. Typically, endometrial cancer is treated by surgery. So we need the surgeon to do a radical hysterectomy. But depending on certain risk factors, we may decide that the patient needs adjuvant radiation and or chemotherapy. We look at the risk factors for recurrence, which are the histology. Some types of cells, like the serous or the clear cell, is a more aggressive cancer over the endometrioid. We look at the grade 1, 2, and grade 3. Grade 3 is a more aggressive cancer. That's what the pathologist tells us. How deeply does the endometrial cancer invade into the myometrium? Does it go beyond 50% of the wall thickness? If it does, there's a higher risk of recurrence. Was the cervix involved? The deep levels of the cervix, the cervical stroma, that's a higher risk for recurrence. And also, was there lymph node spread? So by looking at a combination of these different risk factors, we can decide, the medical oncologist and the radiation oncologist, is the patient at risk for a local recurrence in the vaginal vault or the parametria, the tissues right around the cervix or the endometrium, in the lymph nodes, which is a regional recurrence, or a systemic recurrence. Based on these risk factors, we'll decide on what type of adjuvant therapy or both we need to offer the patient. Next slide. What constitutes high risk? I mentioned serous and clear cell histology, deeply invasive tumor. Stage 2B, which is deep cervical involvement. Stage 3, peritoneal or pelvic satellite lesions, or stage 4, where the lymph nodes have spread. Next slide. If we feel the patient needs external beam radiation, there are really two types of external radiation. That's where the radiation comes from outside the body, the teletherapy, into the patient. The first is a photon or an X-ray. You see a linear accelerator on the left-hand side that sends high energy X-rays into the patient. They come in one side, they go out the other. That machine arcs around the patient, comes in from many different angles, so all the beams add up into a very high target dose with a smattering of radiation around it. The other is a proton cyclotron. There are 25 proton machines in the country that are active and operating. We have one of them. And a proton is a particle which shoots into the target, shoots into the tumor, and stops. And it gives off all of its energy as it stops. So there's less of that normal tissue that gets the low dose of radiation. The cure rate's the same. The toxicity may be a little bit less with protons, and that's something that we decide with the patient as to which might be the better option for her. Next line. If we're concerned that the woman may just have a vaginal recurrence based on cervical involvement, we may offer vaginal cuff brachytherapy. Unlike the cervix, where we want to stick the tandem.
Can you guys hear me at all? Can you
Yes.
hear me now? Mike, give me a thumbs up if you can hear me. Okay, I can't hear anything at this point, so I'm going to have to call in a second. I'm sorry, I'm not sure what happened with my laptop. Did you hear about the vaginal cuff brachytherapy? Give me a thumbs up if you did. Okay, next slide. This is our high dose rate brachytherapy machine. This is a fairly new addition to our radiation armamentarium. It houses a very active iridium-192 source. The iridium source can go through those yellow tubes and into the patient, into one of those apparatuses that we showed you. Because it's computer controlled, the physician doesn't have to be inside the room to do it. In the old days of even 15, 20 years ago, we had to handle the radioactive source and physically put it into the patient. We got exposed. Because we had to handle it, we used a low dose rate source of cesium-137, and the patient had to lie in a room that was lead lined, and we put lead all around the bed so that we could stand there, but still we got exposure. With this, we can put the apparatus in, we attach the HDR machine to the patient through those transfer tubes, and then the iridium source delivers the dose of radiation inside the patient. This has dramatically improved and decreased the time that the woman has to have the apparatus in her from hours and days to just minutes. Next slide. So with patients who have risk for local or regional recurrence, we can offer them either pelvic radiation, external, as I mentioned, the teletherapy, 25 to 28 days. They may get chemotherapy, and with either of these, they may get the vaginal brachytherapy. And it really depends on which risk factors they had. Now, the GOG study, the Gynecologic Oncology study, compared women who got vaginal brachytherapy and chemo to external beam radiation. The cure rate was the same. It seemed that there was a little more toxicity with chemotherapy in the short term, a little bit more toxicity for women with the pelvic radiation in the long term. So we really have to decide, since the cure rates are virtually identical, whether the patient needs chemotherapy to minimize her risk of systemic disease. And if so, then we can get by with just the vaginal brachytherapy. The PORTEC, which stands for Postoperative Radiation Therapy in Endometrial Cancer 3 trial, compared women, randomized women to get chemo and radiation to radiation alone, and showed that there was a higher overall survival when chemotherapy was added. So that now is a standard of care for women who have high-risk disease. Next slide. So there are different ways that we can coordinate the chemotherapy and radiation therapy. We can give it concurrently at the same time. Sometimes we'll give sandwich therapy, 3 cycles of chemo, radiation, and then 3 more cycles. Or we can give it sequentially with the chemotherapy first, followed by the radiation. And because endometrial cancer is so heterogeneous and the risk factors are so diverse, histology, grade, depth of invasion, cervical involvement, lymph node involvement, there really is no uniform approach. And it requires a lot of communication between the handsome medical oncologist and radiation oncologist to figure out how to best choreograph the treatment for these women. And that's my part of the presentation. Mike, you can take over. I'm going to try to call in so I can answer questions.
It is interesting that the chemotherapy that is used for ovarian cancer is the same chemotherapy which is successful when it is needed for cervical cancer or when it is needed for endometrial cancer. It is also curious that the same chemotherapy that we use, which go by the name of carboplatin and Taxol, can be given at the same time as radiation therapy. They work hand in hand, and the effect may be more successful. As noted by Dr. Soffen, there may be more side effects, and that is why we oftentimes adapt and adjust the treatment by giving lower doses on a weekly basis, rather than giving it in higher doses every 3 weeks. We give chemotherapy for endometrial cancer only when it is in the more advanced stages of disease. There are 2 main forms of endometrial cancer. They are listed here, as I've shown, as so-called type 1 and type 2. Type 1, which is listed as endometrioid, they use that word because it means that under the microscope, it looks very much like a normal endometrium. It usually is growing slowly. It usually looks rather mature. And the stages are oftentimes very, very early, stage 1 or stage 2. It usually occurs because of having high levels of estrogen for long periods of time. Women who have a large volume of body fat have higher estrogen levels. That is why, in addition to having the good result of lower incidence of osteoporosis because of high estrogen levels, they have a higher incidence of endometrial cancer. And they have certain genetic changes that I've listed there. On the right, type 2 are the more uncommon and more serious forms of non-endometrial cancer called serous and clear cell. These are growing more rapidly and are called high grade, and they often present with more advanced stages. But having said that, they are both curable. The one on the left, which is slow, is usually treated with surgery and, when necessary, radiation therapy. As Dr. Soffen mentioned, the most common indication being growing through more than half of the muscular wall. On the right side, though, for any stage of disease, even stage 1, we give chemotherapy in conjunction with radiation therapy because it is a fast-growing, high-grade, more dangerous disease. Even stage 1, limited to the endometrium, is an indication for giving chemotherapy for that. As I mentioned, for ovarian cancer, there are certain pathways that tell us what kinds of treatment to use. The same holds true for endometrial cancer. There's a disorder, molecular disorder, called microsatellite instability. It's commonly seen in the well-differentiated slow-growing, mature form, that type 1 that I showed you on the previous slide. And it's seen in at least 20%, called microsatellite instability. This particular population, we also see in women who come from families where there may be colon cancer, occasionally stomach cancer, and occasionally cancers of the sebaceous glands of the skin, called sebaceous carcinomas. That's called Lynch syndrome. And endometrial cancer is seen in up to 30% of women who come from those families. The particular molecular mechanism of it means that the DNA repair pathway is abnormal, and that remarkably provides and confers a sensitivity to the immune therapies that you hear on TV and on radio as advertised every day. We use them in almost every instance of lung cancer now, certainly for advanced lung cancer, and the middle to middle advanced stages of lung cancer called stage 3. But we are now using it rather routinely in endometrial cancer because of the sensitivity which is seen. And we use immunotherapy. I've listed 3 of the common forms of immunotherapies that are approved for endometrial cancer. Anytime it has high risk or has already relapsed. In the serous form, the so-called type 2 of endometrial cancers, there is HRD, or DNA strand repair abnormality, as I taught you early in our discussion. And in this instance, the PARP inhibitors that I mentioned and listed are available for use. Well, quite remarkably, very recently was approved the use of an oral drug called lenvatinib with an IV immunosuppressive drug called pembrolizumab, and even in advanced stage endometrial cancer, after chemotherapy has been used, the response rate, which used to be no greater than 10%, is now over 40%. And for those who have microsatellite instability high, the MSI-H, the response rate could be as high as 64%, a remarkable benefit. So we have learned to combine an oral drug with pembrolizumab. The advantage of this is that there's virtually trivial side effects. The lenvatinib may cause some diarrhea or skin rash, but there is no vomiting, there is no hair loss, there is no effect on the blood counts. The pembrolizumab may cause diarrhea and a skin rash like the lenvatinib, and a number of other side effects which are uncommon and usually very well tolerated. But in combination, the responses for MSI high are 2 out of 3, and even for MSS stable, almost 40%. Dramatic responses that are replacing the old world responses of no more than 10%. And we are applying this, and I have several people on this combination right now with outstanding responses. Immunotherapy is now approved for women with microsatellite instability, high forms of endometrial cancer. And you'd say, well, is the landscape for treatment still flat since that was approved in 2017? Well, I'm now going to show you the landscape of treatments which are available for endometrial cancer as of today. Quite remarkable breakthroughs. Nearly every woman, microsatellite stable or unstable, can now be treated with the lineage of treatment I just showed you. We have dramatic responses to help women who have advanced endometrial cancer, just as we have remarkable treatments available for women who have recurrence of ovarian cancer. We have expanded the landscape, I would call it, because it's treatment that's literally out of this world, a moonscape of treatment. And it's going to be out of even our solar system before you know it. We've made amazing breakthroughs for every form of gynecological cancer, whether it be ovarian, cervical, or endometrial. Certainly we get worried, we get frightened, If we ourselves or a beloved one are suffering through those diseases, our heart goes out to them. But we hope, Dr. Soffen and I hope, that our presentation to you tells you that we are making remarkable progress. This is not just a landscape, it's a moonscape, and we are going out of the solar system now and really making outstanding progress. There is hope for every form of ovarian, cervical, and endometrial cancer as of today. We thank you for listening. We will take I believe we are able to take a couple of questions. For those who are celebrating, we wish you a healthy and happy New Year.
Okay, so we have two questions in the chat right now. One is the interstitial radiation done with anesthesia?
Absolutely. When we put the needles in, the woman has to be under general anesthesia. We can often take the needles out later in the day without anesthesia, just with a little patient-controlled pump. They can give themselves a little bit of morphine or Dilaudid. A minute or two later, we pull the needles out, and it doesn't require going back to the operating room.
Okay, and then can radiation or chemotherapy be repeated?
Well, certainly chemotherapy can be repeated if there has been a long interval between the initial treatment and a reoccurrence, and it depends on which gynecologic malignancy you're referring to. But the answer is usually yes, with greater responses if there's a long disease-free interval. But we can certainly retreat with our modalities, and we oftentimes change from chemotherapy to biologic therapies, which mean antibody therapies, to immunotherapies, or to the PARP inhibitors. When I was listening to Dr. Soffen's presentation, I didn't hear quite so well for a moment. When he was talking about teletherapy, I thought he was talking about telepathy. And I didn't see how telepathy would be able to treat a malignancy, but then it made it clear. It's my way of saying that we are always thinking and trying to think ahead of the curve to help our patients.
Fantastic. With regard to radiation, typically in the past we would say each area of the body can receive radiation one time. To give it a second time does put the normal tissues at risk. However, now with proton beam, with the fact that the proton can fire into the target, we do find that we have the capability sometimes to retreat in the pelvis. If X-rays were used initially, we can use protons a second time. Hopefully we don't have to, but let's say a woman has a gynecologic cancer and then develops a cancer in another part of the body, we can use radiation clearly in that area. But if we're going to retreat an area that has already seen radiation, we would probably use protons.
Okay, and another question about if there are any trials for uterine leiomyosarcoma.
Leiomyosarcomas are rare malignancies.
Leiomyosarcoma is one of the three types of sarcomas, soft tissue cancers of the uterus. It arises within the muscle, and typically it's a surgical procedure to remove the uterus. Oftentimes we give radiation afterwards to minimize the risk of recurrence. It's unusual enough, it's rare. I don't want to say it's rare, but it's unusual enough that there really aren't enough women to go on trials where we can study it. Most women who have fibroids, those are leiomyomas, those are benign tumors of the muscle. On rare occasion, like I said, rare, one of those leiomyomas can become malignant. But I'm not aware now of any trials looking at local treatment. Perhaps, Mike, you know of something in terms of immunotherapies or systemic therapy. I don't know.
When I'm confronted by a leiomyosarcoma, I usually call my sarcoma colleagues to see if they have an active trial going on. They are usually incorporated into trials on soft tissues, on malignancies.
Okay, I think that's it for questions. So I just want to thank you, Dr. Soffen and Dr. Nissenblatt, for taking the time to present on this topic and to answer our questions. The next topic in the series is managing the side effects of cancer on October 16th. And thank you everyone for joining us today, and take care and stay safe.
Thank you for joining us for this week's Encore presentation. To join us for live programs or to learn more about the East Brunswick Public Library, visit our website at ebpl.org.